Dementia is not one disease, and this is the mistake that quietly damages families every day. Someone forgets names, and everyone says Alzheimer's. Someone starts seeing things that are not there, and everyone says they are just confused. Someone becomes rude, impulsive, careless with money, or suddenly loses empathy, and the family says it is personality. Someone walks slower, falls more, leaks urine, and becomes forgetful, and everyone assumes the brain is simply aging. But dementia has many types, and each type can begin differently, progress differently, and require a different kind of care. If you only know the word dementia, you may miss the real warning pattern, and if you miss the pattern, you may lose precious time, choose the wrong care plan, misunderstand the person you love, or mistake a treatable condition for permanent decline. So let us make this very clear from the beginning. Dementia is not normal aging. Normal aging may mean walking into a room and forgetting why you came in, then remembering later. Dementia means the brain changes are strong enough to interfere with daily life, judgment, safety, language, money management, medication use, driving, cooking, hygiene, or relationships. Dementia is an umbrella term, like saying heart disease. Under that umbrella are several different conditions. Some are common, some are rare, some move slowly, some move frighteningly fast, some begin with memory loss, some begin with behavior, some begin with movement, some begin with hallucinations, some are partly preventable, some have treatable contributors, and some are not even true dementia at first, but dementia mimics, such as depression, medication side effects, thyroid problems, vitamin B12 deficiency, infections, sleep apnea, alcohol-related brain injury, or normal pressure hydrocephalus. That is why guessing is dangerous. The first and most common type is Alzheimer's disease. This is the one most people know, and it is the most common cause of dementia. Alzheimer's often begins quietly with short-term memory trouble. A person asks the same question again and again. They misplace objects in strange places. They forget recent conversations. They repeat stories. They may remember events from 40 years ago, but not remember what happened this morning. This happens because Alzheimer's disease often damages memory networks early, especially areas important for forming new memories. But Alzheimer's is not just forgetfulness. Over time, it can affect language, orientation, reasoning, judgment, and daily function. The person may get lost on familiar roads, struggle with bills, forget appointments, stop cooking safely, or become suspicious because they cannot remember where things went. Families often say, "He remembers his childhood perfectly, so it cannot be dementia." That is wrong. Early Alzheimer's often preserves old memories while damaging new memory formation first. Another common mistake is thinking that because someone can talk well socially, they must be fine. Many people with early Alzheimer's can still smile, joke, and cover mistakes, especially during a short visit. But daily life tells the truth. Is the refrigerator full of expired food? Are bills unpaid? Are medications missed? Is the person repeating the same phone call 3 times a day? Alzheimer's usually progresses gradually, but the speed varies. There are medications that may help symptoms for some people, and newer treatments may be considered in selected early cases, but no treatment works for every person, and early diagnosis matters because safety, planning, medications, driving, finances, and caregiver support all need time. The second major type is vascular dementia, also called vascular cognitive impairment, when it is milder. This type is caused by problems with blood flow to the brain. Sometimes it happens after a major stroke. Sometimes it comes from many small strokes or damage to tiny blood vessels over years. The warning pattern can be different from Alzheimer's. Memory may be affected, but often the bigger early problems are slowed thinking, poor planning, trouble organizing, difficulty focusing, reduced mental speed, and problems with decision-making. Families may say, "She can remember things, but she cannot manage tasks anymore." That can be vascular. Another clue is a stepwise decline. The person seems stable, then suddenly gets worse after a stroke or small vascular event, then stabilizes again, then drops again. But vascular dementia can also decline gradually when small vessel disease builds over time. The risk factors are the same enemies that damage the heart: high blood pressure, diabetes, high cholesterol, smoking, obesity, sleep apnea, atrial fibrillation, kidney disease, and lack of physical activity. This is why vascular dementia is so important. Some of its risk factors can be controlled. You may not be able to reverse the damage already done, but you can reduce the chance of more damage. Blood pressure control, diabetes control, cholesterol management, smoking cessation, exercise, sleep apnea treatment, stroke prevention, and taking prescribed blood thinners or antiplatelet medicines only when appropriate can matter. Vascular dementia also teaches a hard truth. The brain is a blood vessel organ. If you ignore blood pressure for 20 years, the brain pays. If you ignore diabetes, the brain pays. If you ignore atrial fibrillation, a clot can travel to the brain and everything can change in one morning. The third type is dementia with Lewy bodies, and this one is often missed because it does not always start like typical Alzheimer's. Lewy body dementia is linked to abnormal deposits of a protein called alpha-synuclein, known as Lewy bodies. The pattern can include fluctuating attention, visual hallucinations, movement changes, sleep problems, and thinking difficulties. Fluctuation is a major clue. One day the person seems sharp, the next day they are deeply confused. In the morning they may follow conversation, and in the afternoon they may stare, lose track, or seem unreachable. Families may wonder if the person is pretending or being difficult. They are not. The brain's alertness system may be fluctuating. Visual hallucinations are another clue. A person may see people, animals, children, insects, or shapes that are not there. Sometimes the hallucinations are detailed and repeated. Movement symptoms can look like Parkinson's disease: stiffness, slow movement, shuffling steps, reduced facial expression, smaller handwriting, and falls. Sleep can also give a clue, especially REM sleep behavior disorder, where the person acts out dreams, talks, kicks, punches, or seems to fight in sleep. This can appear years before dementia. Lewy body dementia is important because people with it may be very sensitive to certain antipsychotic medications. Some drugs used for hallucinations or agitation can cause severe worsening, stiffness, sedation, or dangerous reactions. That does not mean symptoms cannot be treated. It means treatment must be careful, knowledgeable, and individualized. If a person has dementia plus vivid hallucinations, major fluctuations, Parkinson-like movement, repeated falls, and dream enactment, do not assume it is just Alzheimer's. Ask about Lewy body dementia. The fourth type is Parkinson's disease dementia. This is related to Lewy body disease, but the timing is different. In Parkinson's disease, movement symptoms such as tremor, stiffness, slowness, and shuffling gait usually come first. Dementia may develop later, often years after the movement diagnosis. In dementia with Lewy bodies, cognitive problems and hallucinations often appear before or around the same time as movement symptoms. This timing helps doctors classify the condition, though the underlying biology overlaps. Parkinson's disease dementia can affect attention, visual spatial ability, planning, memory retrieval, mood, sleep, and hallucinations. A person may struggle with depth perception, driving, finding objects, following complex tasks, or staying alert. Families may focus only on the tremor, but the cognitive changes can become more disabling. Treatment often requires balancing movement medicines, cognition, hallucinations, sleep, and blood pressure. Too much medication may worsen hallucinations. Too little may worsen movement. This is why specialized care matters. The fifth type is frontotemporal dementia, often called FTD. This one can be devastating because it often begins earlier than Alzheimer's, sometimes in the 40s, 50s, or early 60s, and it may not begin with memory loss. Instead, it can begin with personality, behavior, judgment, empathy, impulse control, or language. In behavioral variant frontotemporal dementia, the person may become socially inappropriate, rude, impulsive, reckless with money, sexually inappropriate, obsessed with certain routines, emotionally cold, apathetic, or unable to understand other people's feelings. Families often say, "This is not the person I married." And because memory may still seem okay at first, Doctors or relatives may mistake it for depression, midlife crisis, addiction, narcissism, or a psychiatric disorder. The person may make terrible financial choices, eat compulsively, lose manners, stop caring about hygiene, or seem selfish. But the problem is not simply bad character. The frontal and temporal lobes, the brain regions involved in behavior, social judgment, emotion, and language, are being damaged. Another form of FTD affects language, called primary progressive aphasia. A person may struggle to find words, understand words, speak fluently, or name objects. They may know what they want to say but cannot produce it. Or they may speak fluently but lose word meaning. FTD is especially hard for families because the person may not understand they are impaired. They may resist help. They may look physically healthy. They may be too young for people to suspect dementia, but recognizing FTD matters because care strategies are different. Memory reminders may not help much if the core issue is impulse control or language. Safety, supervision, financial protection, behavior management, and caregiver support become urgent. The sixth type is mixed dementia. This is extremely important after 70 and 80. Many people do not have one pure disease. They may have Alzheimer's changes plus vascular damage, or Alzheimer's changes plus Lewy bodies, or vascular disease plus Lewy body disease. The brain can hold more than one pathology at the same time. This is why symptoms may not fit neatly into one box. A person may have Alzheimer-like memory loss, vascular-like slowed thinking, and Lewy-like hallucinations or fluctuations. Families may get frustrated because one article says Alzheimer's begins this way, another says vascular dementia behaves that way, but their loved one has both. Mixed dementia is one reason older adults need comprehensive evaluation rather than labels thrown around casually. It also shows why prevention still matters even after symptoms begin. If Alzheimer's pathology is present, controlling vascular risk factors can still protect remaining brain function. If blood pressure is uncontrolled, if diabetes is wild, if sleep apnea is untreated, if strokes keep happening, the dementia burden can worsen. You may not be able to remove every disease process, but you can stop adding fuel to the fire. The seventh type is late, which stands for limbic predominant age-related TDP-43 encephalopathy. Most people have never heard of it, but it matters, especially in very old adults. Late can look like Alzheimer's because it often affects memory, but the underlying protein problem is different. It is more common in advanced age, especially after 80. This is one reason some older adults appear to have Alzheimer-type memory loss, but the pattern, progression, or test results do not match perfectly. Late is still an area of active research, and it is not something families usually diagnose on their own. But the practical message is important. Not every memory loss dementia in the oldest old is classic Alzheimer's. The brain aging landscape is more complex than one label. The eighth type is normal pressure hydrocephalus, often shortened to NPH. This condition is sometimes described with a classic triad: walking problems, urinary problems, and thinking problems. The walking change is often the biggest clue. The person may walk with short, shuffling steps, as if their feet are stuck to the floor. Balance worsens, falls increase. Then memory or thinking becomes slower, and bladder urgency or incontinence appears. NPH happens when cerebrospinal fluid builds up in the brain's ventricles and disrupts brain function. Why does this matter so much? Because NPH can sometimes improve with treatment, especially with a shunt procedure in carefully selected patients. It is not always reversible, and not everyone benefits, but missing it can be tragic. Many people with NPH are mislabeled as Alzheimer's or Parkinson's because they are older, forgetful, and walking poorly. If the strongest early symptom is gait trouble, especially a magnetic, stuck-to-the-floor walk, plus urinary urgency and cognitive decline, ask whether NPH has been considered. This is one of the reasons every dementia evaluation should include a careful history, neurological exam, and often brain imaging when appropriate. The ninth type is alcohol-related dementia and Wernicke-Korsakoff syndrome. Long-term heavy alcohol use can damage the brain directly and also cause severe thiamine or vitamin B1 deficiency. Wernicke's encephalopathy can be an emergency with confusion, poor coordination, and eye movement problems, though not every person has all three. If not treated quickly with thiamine, it can progress to Korsakoff syndrome, where severe memory problems and confabulation can occur. Confabulation means the brain fills memory gaps with made-up information, not because the person is lying, but because the memory system is damaged. Alcohol-related cognitive impairment can sometimes improve partially with abstinence, nutrition, and treatment, depending on severity and timing. This is another reason not to assume all dementia is untreatable. If alcohol use, poor nutrition, repeated falls, liver disease, neuropathy, or confusion is part of the story, the evaluation must include nutritional and alcohol-related brain injury. The 10th type is dementia related to Huntington's disease. Huntington's is an inherited genetic disorder that can cause movement problems, psychiatric symptoms, and cognitive decline. The movements may be jerky or dance-like, called chorea, but some people also develop stiffness or slowness. Mood, irritability, depression, impulsivity, and judgment problems may appear. Cognitive decline often affects planning, flexibility, organization, and self-control. Because Huntington's is genetic, family history is important. It often appears earlier than typical late-life dementia, though timing varies. This condition requires specialized neurological and genetic counseling support because the diagnosis affects entire families, not just one person. The 11th type is Creutzfeldt-Jakob disease, or CJD, a rare prion disease. This is not common, but it is important because it progresses very rapidly compared with most dementias. A person may decline over weeks or months, not years. Symptoms can include rapidly worsening memory and thinking, personality changes, movement problems, muscle jerks, vision problems, coordination issues, and severe neurological decline. Rapid dementia is a medical red flag. If someone changes dramatically in a short time, do not assume ordinary Alzheimer's. Rapid decline can come from infections, autoimmune brain disease, seizures, medication toxicity, metabolic problems, cancer-related syndromes, prion disease, or other serious conditions. Rapid decline needs urgent medical evaluation. The 12th type is chronic traumatic encephalopathy, often called CTE. This is associated with repeated head impacts, such as in some contact sports, military blast exposure, or repeated traumatic brain injury. Symptoms can include mood changes, impulsivity, depression, aggression, memory problems, and later cognitive decline. CTE can only be definitively diagnosed after death, so it is often discussed carefully during life as suspected traumatic encephalopathy. The practical message is that repeated brain injury matters. If a person has a history of many concussions or head impacts and later develops mood, behavior, impulse, and cognitive problems, clinicians may consider traumatic brain injury effects among other causes. The 13th category is dementia due to medical conditions, infections, immune problems, medication, toxicity, or metabolic disorders. This is where families must be careful because some causes of cognitive decline can be treated or improved. Low thyroid function can slow thinking. Vitamin B12 deficiency can cause memory problems, neuropathy, and balance issues. Depression can look like dementia, sometimes called pseudo-dementia, though depression and dementia can also coexist. Urinary infections, pneumonia, dehydration, low sodium, high calcium, liver failure, kidney failure, and medication side effects can cause confusion, especially in older adults. Delirium is a sudden change in attention and awareness, and it is not the same as dementia. Delirium can happen quickly, fluctuate through the day, and often signals illness or medication reaction. A person with dementia can also develop delirium on top of dementia, making them suddenly much worse. This is why sudden confusion should not be brushed off. If someone is fine 1 week and severely confused the next, look for infection, medication changes, dehydration, stroke, seizure, metabolic problems, or hospitalization-related delirium. Do not just say, "The dementia got worse." Dementia usually changes over months or years. Sudden change demands investigation. Now let us talk about the warning patterns that help separate these types in real life. If the first and strongest symptom is forgetting recent conversations, repeating questions, misplacing things, and gradually losing memory, Alzheimer's is often considered. If the main issue is slowed thinking, poor planning, trouble focusing, and there is a history of stroke or vascular risk factors, vascular dementia becomes more likely. If there are visual hallucinations, big fluctuations in alertness, dream enactment, falls, and Parkinson-like movement, think about Lewy body dementia. If movement symptoms came years before dementia, think about Parkinson's disease dementia. If the first signs are personality change, poor judgment, loss of empathy, compulsive behavior, or language breakdown, think about frontotemporal dementia. If the symptoms are memory loss, plus stroke-like thinking problems, plus hallucinations or movement signs, mixed dementia may be present. If walking becomes strange and magnetic, with urinary urgency and cognitive slowing, ask about normal pressure hydrocephalus. If decline is very rapid, over weeks or months, treat it as urgent. If alcohol and malnutrition are part of the story, consider thiamine deficiency and alcohol-related brain injury. If there is repeated head trauma, consider traumatic brain injury effects. If symptoms suddenly worsen, think delirium until proven otherwise. This pattern-based thinking can save families from years of confusion, but no family should be expected to diagnose dementia alone. A proper evaluation may include history from someone who knows the person well, cognitive testing, medication review, blood tests, neurological exam, brain imaging, sleep evaluation, depression screening, and sometimes specialist referral. The person with dementia may not recognize their own decline, so family observations matter. Bring examples. Do not just say, "Memory is worse." Say, "She paid the same bill 3 times. He got lost driving home. She left the stove on. He gave money to a scammer. She sees children in the room at night. He started making sexual comments in public. She acts out dreams and has fallen twice." Specific examples help doctors identify the pattern. Now, what can you do once dementia is suspected or diagnosed? First, stop pretending it is just age. Denial wastes time. Second, review medications. Some sleeping pills, anxiety medications, bladder medications, pain medications, antihistamines, and other drugs can worsen confusion or memory in older adults. Third, protect sleep. Poor sleep worsens cognition. Sleep apnea should be treated. Fourth, protect hearing and vision. A person who cannot hear or see well may appear more confused, and sensory loss increases isolation. Fifth, control vascular risks. Blood pressure, diabetes, cholesterol, smoking, exercise, and atrial fibrillation matter. Sixth, plan safety early. Driving, cooking, firearms, scams, wandering, falls, medication management, and finances need honest discussion before crisis hits. Seventh, support the caregiver. Dementia does not affect one brain only. It affects an entire household. Caregiver exhaustion is real, and it can become dangerous. Eighth, preserve dignity. The person is not a diagnosis. They are still a human being with fears, preferences, history, and moments of connection. The way you speak matters. The way you correct matters. The way you help matters. Arguing with a damaged brain often fails. Structure, routine, calm tone, simple choices, and safety work better than lectures. There is one more truth that families need to hear. Different dementia types can react differently to the environment. A person with Alzheimer's may need memory cues and routine. A person with Lewy body dementia may need careful management of hallucinations, sleep, movement, and medication sensitivity. A person with FTD may need stronger supervision around money, food, social behavior, and safety because they may not feel concern. A person with vascular dementia may benefit from stroke prevention and structured problem-solving support. A person with NPH may need evaluation for possible treatment. A person with alcohol-related injury needs nutrition, abstinence support, and medical care. The label is not just a label, it changes the plan. So if you remember only one sentence from this, remember this: dementia is not one road. It is many roads that can look similar from far away, but very different up close. Alzheimer's is the memory road. Vascular dementia is the blood flow road. Lewy body dementia is the hallucination, fluctuation, sleep, and movement road. Frontotemporal dementia is the behavior and language road. Parkinson's disease dementia is the movement first road. Mixed dementia is the multiple roads at once road. Normal pressure hydrocephalus is the walking, bladder, thinking road that may sometimes be treatable. Alcohol-related dementia is the nutrition and toxin road. Huntington's is the genetic movement and cognition road. CJD is the rare rapid decline road. CTE is the repeated head injury road. And delirium, depression, medication effects, thyroid disease, B12 deficiency, infection, and sleep apnea are the mimics and amplifiers that must not be missed. This is why a careful diagnosis matters, not because a label fixes everything, but because the wrong label can send you in the wrong direction. If someone you love is changing, do not wait until disaster. Write down the first symptom, the timeline, the safety problems, the sleep changes, the movement changes, the hallucinations, the personality changes, the medications, the alcohol use, the falls, and the family history. Bring that to a doctor. Ask, what type of dementia pattern does this look like? Ask, what treatable causes have we checked? Ask, could this be delirium, depression, medication effect, sleep apnea, B12 deficiency, thyroid disease, stroke, or normal pressure hydrocephalus? Ask, what should we do now to protect safety and independence? These questions can change the entire course of care. Dementia is frightening, but confusion about dementia makes it even more frightening. Knowledge does not remove the pain, but it gives you a map. And when a family has a map, they stop blaming the person for symptoms the brain is causing. They stop waiting for memory loss when the real warning is behavior. They stop calling hallucinations imagination when Lewy body disease may be present. They stop assuming walking problems are only arthritis when NPH may